After studying this module, you shall be able to learn about the concepts of bipolar disorders, learn about the various types of bipolar disorders, identify the neurological basis of bipolar disorders, understand the psychosocial causal factors related with bipolar disorders. Bipolar disorder, also known as bipolar affective disorder or manic depression. It is a mental disorder characterized by periods of elevated moods and periods of depression. The elevated mood is significant and is known as mania or hypermania depending upon the severity or whether there is psychosis. During mania, an individual feels or acts abnormally happy, energetic or irritable. They often make poorly thought out decisions with little regard to the consequences. The need for sleep is usually reduced. During periods of depression, there may be crying, poor eye contact with others and a negative outlook on life. The risk of suicide among those with the disorder is high at greater than 6% over 20 years, while self-harm occurs in 30 to 40%. Other mental health issues such as anxiety disorder and substance use disorder are commonly associated. The cause is not clearly understood, but both genetic and environmental factors play a role. Many genes of small effect contribute to the risk. Environmental factors include long-term stress and a history of childhood abuse. It is divided into bipolar 1 disorder if there is at least one manic episode and bipolar 2 disorder if there are at least one hypomanic episode and one major depressive episode. In those with less severe symptoms of a prolonged duration, the condition of cyclothymic disorder may be present. If due to drugs or medical problems, it is classified separately. Other conditions that may present in a similar manner include substance use disorder, personality disorders, attention deficit hyperactive disorder and schizophrenia, as well as a number of medical conditions. Treatment commonly include psychotherapy and medications such as mood stabilizers or antipsychotics. Examples of mood stabilizers that are commonly used include lithium and anticonvulsant. Treatment in hospital against a person's wish may be required at times as people may be a risk themselves or others yet refuse treatment. Severe behavioral problems may be managed with short-term benzodiazepines or antipsychotics. In periods of mania, it is recommended that antidepressant may be stopped. If antidepressants are used for periods of depressions, they should be used with a mood stabilizers. Electroconvulsive therapy may be helpful in those who do not respond to other treatments. If treatments are stopped, it is recommended that this is done slowly. Many people have social, financial or work-related problems due to the disorder. These difficulties occur a quarter to a third of the time on average. The risk of death from natural causes such as heart diseases is twice that of general population. This is due to poor lifestyle choices and the side effect of medications. DSM-4-TR recognizes three forms of bipolar disorder. First, bipolar 1 disorder, second, bipolar 2 disorder, third, cyclothymic disorder. Many symptoms constitute the defining features of each of these disorders. These are differentiated by how severe and long-lasting the manic symptoms are. First, bipolar disorder 1. DSM-4 criteria: presence or history of one or more manic or mixed episode necessary for the diagnosis. Second, presence or history of one or more major depressive episode not necessary for the diagnosis. The mood symptoms in criteria A and criteria B are not better accounted for by any other disorders. D. The symptoms cause clinically significant distress or impairment in functioning. E. Specify if current or more recent episode is first hypomanic, second manic, third mixed, fourth depressive. Next we will study about bipolar disorder 2. The DSM-4-TR criteria for this are: A. Presence or history of one or more major depressive episodes. B. Presence or history of at least one hypomanic state. C. There has never been a manic episode or mixed episode. D. The mood symptoms in criteria A and B are not better accounted for by schizoaffective disorder and are not superimposed on schizophrenia. Schizophrenia form disorder, delusional disorder or psychotic disorder not otherwise specified. The symptoms causes clinical significant distress or impairment in social, occupational or other important areas of functioning. Specify current or recent episodes. Hypomanic if currently or most recently in a hypomanic episode. Depressed if currently or most recently in a major depressive episode. Next, we will talk about cyclothymia. The DSM-4 criteria for these are: A. For at least 2 years, the presence of numerous periods with hypomanic symptoms and numerous periods with depressive symptoms that do not meet the criteria of a major depressive episode. Note: in children and adolescents, the duration must be at least 1 year. B. During the above two periods, 1 year in children and adolescents case, the person has not been without the symptoms in criteria A for more than 2 months at a time. C. No major depressive episode, manic episode or mixed episode has been present during the first 2 years of the disturbance. Note: after the initial 2 years, in children and adolescents it is 1 year. For cyclothymic disorder, there may be superimposed manic or mixed episode, in which case both bipolar first disorder and cyclothymic disorder may be diagnosed, or major depressive episode, in which case both bipolar 2 disorder and cyclothymic disorder may be diagnosed. D. The symptoms in criteria A are not better accounted for by schizoaffective disorder and are not superimposed on schizophrenia. Schizophrenia form disorder delusional disorder or psychotic disorder not otherwise specified. E. The symptoms are not due to direct physiological effects of a substance, for example, a drug of abuse, a medication or a general medication, example, hyperthyroidism. Next, genetic and neurological factors in bipolar disorder. A host of causal factors of bipolar disorders have been posited over the past century. However, biological causal factors are clearly found to be more predominant than the psychosocial factors. Biological dimension has been studied from several angles such as genetic studies, neurotransmitter and brain structure studies and the functional brain imaging studies, etc. The structure of the cell in a patient of bipolar disorder is shown below. Several investigations such as family studies and twin studies have confirmed the genetic contributions toward the development of bipolar disorder. A summary of studies using refined diagnostic procedures suggests that 8 to 9% of first degree relatives of a person with bipolar disorder illness can be expected to have a bipolar disorder relative to 1% in the general population. Family studies cannot by themselves establish a genetic basis for the conclusion. Investigations involving early twin studies also points to the genetic basis as the concordance rates are much higher for the identical twins than for fraternal twins. McGuffin found out that 67% of monozygotic twins with bipolar disorder had a co-twin who shared the diagnosis. The concordance rate in dizygotic twins was 19%. This and other studies suggest that genes account for about 80 to 90% of variance in the tendency to develop bipolar depression. The analysis of genes, chromosomes, DNA and RNA, the focus of molecular genetic studies, is carried out in the present time to understand the genetic base of mental disorders. The basic structure of the cell is shown below. The studies on molecular genetics have indicated that generally people who have bipolar disorder have an abnormality of their 5-HTT gene. This gene is responsible for the transportation of the neurotransmitter serotonin. The amount of serotonin has been closely linked with depression. Alteration in brain structure occur concurrent with the disorder. Through MRI studies, brain structure abnormalities have been pointed out. Besides searching for genes that result in bipolar disorder, many researchers have found that abnormalities in the structure of the brain also plays an important role in the development of bipolar disorder. The clinical observation that certain brain lesions produced by brain tumor, stroke or head injury resulted in manic-like behavior. The lesions that induce mania occur more commonly in the frontal and temporal lobes and subcortically in the ventral area of caudate and thalamus. It has also been confirmed in many other studies that right frontotemporal lesions produce mania. Earlier, the only method available to examine patient's brain were autopsy, brain biopsy and pneumoencephalography. However, neuroimaging using both computer tomography, that is called CT, and magnetic resonance imaging MRI has revealed multiple structure alterations. Several researchers have suggested that the patients with bipolar disorder have large ventricles than normal controls. Blumberg investigated prefrontal cortex function in the manic state of bipolar disorder using a high sensitivity H2O positron emission tomography, which is also called PET, and a word generation activation paradigm to measure regional cerebral blood flow. They have performed this study with 5 manic and 6 euphemic subjects with bipolar 1 disorder along with 5 healthy control subjects. They found decreased right rostral and orbital prefrontal cortex activation during the word generation as well as decreased bilateral orbitofrontal cortex activity during rest in the manic group when compared to the euphemic and control groups. These results suggest that dysfunction in the rostral and orbitofrontal as well as prefrontal cortex, which may lead to impaired judgment and inappropriate behavioral response to changing inner drive and external environments, are present in the manic state of bipolar disorder given by Blumberg in 1999. Another brain abnormality occur in the basal ganglia. The basal ganglia is a set of subcortical forebrain structure called the striatum, the caudate nucleus and putamen, the globus pallidus located lateral to the hypothalamus. Functionally, the striatum has been divided into associative, sensory motor and limbic region. In one study, Huang investigated shape alteration in basal ganglia related to bipolar disorder. They had two hypotheses. First, shape differences of the caudate heads and putamen, particularly on the right side, exist between the drug-naive patients and the healthy controls. And the second hypothesis is shape differences exist between the drug-naive and drug-treated patients. To test their hypothesis, they imaged the brains of 49 bipolar disorder patients, including 21 drug-naive and 28 drug-related, and 37 healthy controls using magnetic resonance imaging, which is called MRI. Then from the MRI images, they measured the volume of their brains and analyzed their shape using spherical harmonic description, which is a shape analysis technique capable of detecting subtle structure alteration in small brain structures. They did not find significant volume differences in the striatum between the subject groups. However, they found significant shape difference in the anterior and the posterior surface of the striatum, especially on the right hand side, between drug-naive patients and two other groups, which were drug-treated patients and healthy controls. Since shape difference were observed in the drug-naive patients, not in the drug-treated patients, they concluded that striatum shape abnormalities observed in bipolar disorder may be modulated by the treatment. Studies have also found that cingulate cortex anatomical abnormalities are also related to bipolar disorder. The cingulate gyrus has extensive connection with limbic region and is possibly a key brain structure for mood regulation. Kaur in 2005 studied the cingulate cortices of bipolar children and adolescents using MRI. Their study subjects included 16 children and adolescents with bipolar disorder with mean age of 15.5 and 21 healthy controls with mean age of 16.9. Each of the 4 sessions of the cingulate cortex, anterior, posterior, right and left, was measured for each subject. The bipolar subject group had significantly smaller mean gray matter volume for all the reasons except the right anterior cingulate, where compared to the healthy subject group. Since abnormalities in the cingulate are present early in bipolar disorder, the cingulate may play a keen role in pathophysiology of the disorder and may serve as an early onset marker. Abnormalities in the brain area relating to judgment and emotions such as prefrontal cortex, the basal ganglia and the cingulate have been found in bipolar patient. However, the degree to which these abnormalities cause the disorder is still unclear. However, how the different affected brain areas interact in the pathophysiology is still not understood. Alteration in brain chemistry have also been identified. MR spectroscopy, which is also called MRS, has been used to measure the changes in relative concentrations of various neuroregulators within the brains of bipolar patients. The most frequently used method is proton MRS that measure the relative concentrations of N-acetyl aspartate, serotonin, phosphocreatine and various choline containing compound. It has been found there is an elevated chlorine and serotonin ratio in the basal ganglia of bipolar patient. Changes are evident at virtually all the levels of CNS of bipolar patients as numerous biochemical abnormalities have been detected by measuring one or another neurotransmitter, metabolites or hormones. Depression has been conceptualized as due to relative deficiency of various monoamine neurotransmitters like serotonin, dopamine and norepinephrine. However, these have not been clearly implicated in the pathophysiology of bipolar disorder. However, although NE may not in itself be the causative factor, it is an evidence for the idea of unstable cortical states. In addition to the monoamine neurotransmitters, others have also been implicated, for example glutamate. The researchers are working to find the exact role of glutamate in the development of bipolar disorder. Thus, disturbance in the balance of neurotransmitters seems to be one of the key to understanding this debilitating illness, which can send its victim on an emotional roller coaster. Recently, questions have been raised on the role of lithium in treating bipolar patients. The questions why lithium, the most effective and widely prescribed drug used in the treatment for this disorder, can stabilize the patients from both the depressive and the manic state, in that lithium is closely related chemical to sodium, and sodium plays a key role in the passage of neural impulse down an axon. Thus, it has been anticipated that bipolar patients have abnormalities in the way ions such as sodium are transported across neural membrane. This study is given by Goodwin and Jamison. Some neuroabnormal research on bipolar disorder has focused on the hypothalamic pituitary adrenal axis. Cortisol level of elevated in bipolar depression and also bipolar patients show abnormalities on dexamethasone suppression test. Many bipolar patients have subtle but significant abnormalities of the hypothalamic pituitary thyroid axis, and administration of thyroid hormone often makes antidepressants work better. This is considerable evidence regarding disturbances in biological rhythm such as circadian rhythm in bipolar disorders even when symptoms have mostly remitted. During manic episode, bipolar patients tend to sleep very little, and this is the most common symptoms to occur prior to the outset of manic episode. Psychosocial factors in bipolar disorders. Stressful events appear to be an important factor in precipitating the development of bipolar disorder. Though stressful life events seems to trigger early mania and depression, but as the disorder progresses, these episodes seem to develop a life of their own. In other words, once the cycle begins, a psychological or pathophysiological process take over and ensure that the disorder will continue. In one study, it was also found that patients who experienced negative events took an average of 3 times longer to recover from manic, depressive or mixed depressive episode than those without a severe negative event. There is a positive correlation between negative attribution styles and the onset of mania and depression. Furthermore, two personality variables associated with high level of achievement, striving and increased sensitivity to rewards in the environment predicted increase in manic symptoms. Bipolar disorder, also known as manic depressive illness, is a brain disorder that causes unusual shifts in mood, energy, activity level and the ability to carry out day-to-day activities. Second point, the possible cause of bipolar disorder are complex and are likely to act in a multiplicative manner. Third, a dysfunction in many brain regions associated with these mood regulating circuits may lead to the development of a mood disorder. Fourth point, the main brain areas involved in bipolar disorder include the frontal and the temporal lobes of the forebrain and prefrontal cortex and the basal ganglia and the part of the limbic systems. Fifth point, the structural changes in the hippocampus have also been associated with the disorder. Sixth point, neurotransmitters are also involved in the etiology of mood disorders, especially the monoamines and acetylcholine.